went to Trinity College, then UConn School of Medicine, then Yale for residency, chief residency, fellowship, stayed on at Yale, on faculty for a number of years before recruited to Harvard Healthcare because we were developing a new movement disorder center while I was there. We gained support from several philanthropists to develop what's now the Chase Family Movement Disorder Center. So we're the largest provider of movement disorder care in the state of Connecticut, and we have a variety of different services. So I'm happy to be here to discuss a very important topic in Parkinson's, and that's sleep. So for patients who know me, they know I am a big proponent of the 4 pillars of Parkinson care, the 4 pillars that form the foundation of care. So sleep, diet, exercise, and then medication supplements. So each pillar has to be strong for the foundation to be built upon from there. So it's really important to have each of these 4 pillars be well managed. And I'll discuss one of those 4, and that's sleep today. So today's program agenda is why is sleep effective in Parkinson's, and why is sleep important, and how is sleep impacting Parkinson's. So we're going to discuss common sleep disorders in Parkinson's, and then common Parkinson's symptoms that impact on sleep, and then also discuss excessive daytime sleepiness and fatigue. So sleep disturbances, very common, and it's a common and disabling non-motor symptom of Parkinson's. So up to 90% of people can experience sleep dysfunction in Parkinson's. And why this occurs is because of this famous protein in Parkinson's called alpha-synuclein. So alpha-synuclein has been in the Parkinson's news very recently because the Michael J. Fox Foundation announced in April that there's now a biomarker for Parkinson's called alpha-synuclein. So alpha-synuclein is a protein that we all have, except people that develop Parkinson's have a version of alpha-synuclein called phosphorylated alpha-synuclein. This is a alpha-synuclein that develops a different three-dimensional shape to it, which doesn't allow the brain cells to clear it out appropriately, and so it clumps and clogs the cell and causes the cell not to function properly. Previously, we were able to detect the presence or absence of alpha-synuclein on things like a skin biopsy or other biopsy materials like the gut or salivary glands, but we haven't been able to quantify or know the amount of alpha-synuclein that any individual person has in order to know how advanced a person is or how early on a person is with their Parkinson's. But the Michael J. Fox Foundation announced that we can quantify or actually look at the amount of alpha-synuclein in an individual person in spinal fluid. So clinical trials moving forward will utilize spinal taps in patients to look at spinal fluid, quantify alpha-synuclein, and then introduce some therapeutic and then measure alpha-synuclein levels later on to see whether or not the intervention is actually helping to clear out this abnormal protein in the body. Now, alpha-synuclein, as mentioned, is present throughout the body of people with Parkinson's, this phosphorylated alpha-synuclein, including certain parts of the brain. not only the dopamine cells, but also cells that are critical for release of hormones like melatonin. And so there's a melatonin deficiency in Parkinson's and other neurochemical deficiencies in Parkinson's that dysregulate the sleep. So centers in the brainstem that secrete these neurochemicals that help regulate our circadian rhythm become impaired, and sleep disorders result. So not getting a good night's sleep causes worsened motor symptoms and worsened cognition also. So poor sleep also sets up a vicious cycle where poor sleep leads to daytime sleepiness, excessive daytime napping, and then poor sleep again, and this concept of sleep fragmentation. So sleep consolidation is what we try to achieve, not sleep fragmentation, where it's broken up into segments. Now, one may say, well, how does not getting a good night's sleep cause worsened motor symptoms? Because while we sleep, our brains are making melatonin, dopamine, and storing it. And so if we're not sleeping properly, our cells' ability to make sufficient dopamine for the following day is impaired, so there's less dopamine. There have been studies also looking at exercise and sleep. So they took groups of patients, one group where they did high intensity of exercise and they got good sleep, another group where they did high intensity exercise and poor sleep, and then the third group where they just looked at their overall sleep without exercise. The group that did best was those that got adequate exercise, high intensity, and good sleep. Interestingly, the group that got poor sleep, it negated the beneficial effect of exercise entirely. So it's really critical that you get both, that exercise and good sleep, that getting poor sleep can really negate the benefits of even exercise. That's how powerful an issue getting a good night's sleep is. And of course, sleep is one of the most treatable causes for cognitive dysfunction. So I do a simple test when I see patients in clinic, which is a test of attention. And so if you're a neurologist, I'm sure I've done this, where they ask you to start with the number 80, for example, and subtract by 7, the serial sevens task. That's a task of attention. If people can't do that well, I delve into asking about sleep, because that means that a person's not attentive. I'm not testing your arithmetic skill, I'm testing how well you're attentive to the task. People who lose their train of thought, they can't subtract by 7, may indicate that they're not sleeping well, and if they're not, I don't do any further testing until I improve their sleep, because that's how potent an impact sleep is also having on cognitive function. Trying to advance this. So when I say that we then look at evaluating sleep further, the best way to do this is with a sleep study, a polysomnography study. This can be done at a sleep center at home. We always prefer at a sleep center because so much more data can be achieved at a sleep center. Truly, the reason to get it at home is if we have a high pre-test probability that person has sleep apnea, obstructive sleep apnea. So for people who have obstructive sleep apnea, doing a home study would be sufficient. We're monitoring their oxygen levels and seeing if they drop down due to excessive snoring, turbulence of airflow. But if a person has a variety of some other sleep disorders, the data that we get at home is not going to be sufficient to make a proper diagnosis. That data includes looking at brain waves. So they attach stickers to the scalp, they're connected to a machine that looks at the brain rhythms at different stages of sleep. The heart rate, breathing, leg and eye movements. The eye movement monitoring is critical to know if a person's in REM sleep or not. So rapid eye movement sleep. So that's a deep state of sleep. And leg movements also important since I'll discuss some leg movement disorders that result in sleep dysfunction.
But go ahead.
It has to be like this. Yeah, thanks for your hands.
Thank you.
So there are various stages of sleep. So at the top you'll see awake, and then REM sleep in red, that red line. Non-REM sleep, non-REM sleep stage 1, 2, and 3. And our sleep schedule is divided into these various stages. So we start transitioning into from awake, this first line, from awake down to stage 1, stage 2, stage 3, and then at some point we transition into REM sleep. And as shown, we should enter about 4 REM periods in the middle, over the course of a night. Shown here from 11 p.m. to 7 a.m., for example. If we awaken from a REM sleep, as shown in that last cycle, cycle 5, that the line goes from REM sleep to awake, that's when we'll recall our dream. So if we awaken at some other point in the cycle, then we won't recall our dream because it's necessarily because we weren't in that stage right before we awaken. About 20% of our time is spent in REM sleep. And this is important because this stage is quite impaired in Parkinson's, as I'll show. Now, what can happen in Parkinson's is that unlike the top, which is a normal stage of sleep, over time, the sleep can become very fragmented. So each time this goes up to the top, each of these is a person awaking out of sleep. So this person will multiple times over the course of the evening, and by doing so, notice what happens. There's a lack of stage 3 sleep present compared to a younger adult where there's more stage 3. So stage 3 is where a lot of learning and memory consolidation occurs. Like the thoughts of the day become filed in the appropriate places in the brain, and so if you're not getting sufficient stage 3, then that's going to affect on learning and memory as well. So sleep consolidation and avoiding these multiple interruptions is goal. Now, how do we avoid these interruptions? I'll show you in the next few segments about some sleep disorders that are treatable if identified properly. So these are the very common sleep disorders seen in Parkinson's. So there's REM, behavioral sleep disorder. There's primary and secondary insomnias, circadian rhythm disorders, restless leg syndrome, periodic limb movement disorder, and then sleep apnea or some other sleep breathing disorder. REM behavioral disorder, this is very common, and even before the onset of motor symptoms, this is a common thing that people experience. It's so common before the onset of motor symptoms that whenever I see a patient in clinic that I'm seeing for the first time, where there's a question about whether Parkinson's is a diagnosis, I'll ask, is there the occurrence of REM behavioral sleep disorder? If the answer is yes, then that increases the likelihood that their diagnosis is Parkinson's. So what REM behavioral sleep disorder is the emergence of verbal or motor activity during REM sleep. So a person can act out their dream. So they can cause or exhibit sudden violent movements of the limbs, shouting out, yelling, thrashing, falling out of bed as a result. So injuring themselves and or their bed partner as a result of this. Now why this happens is because there is a loss of cells in a part of the brainstem that regulates the process of shutting down our motor symptom while we dream. So normally what happens is when we dream, there's a switch in the brainstem that shuts off so that what we're thinking about, so as an example, if you think about swinging a golf club, you don't actually start moving your arm as a result, even though the brain cells are actively processing that signal hits the brainstem and stops there. It doesn't travel down the spinal cord into our limb. But in Parkinson's, instead of an on-off switch, think of it like a dimmer switch. So sometimes it's off all the way, sometimes it's not. It's just turned down a little bit. And that makes REM behavior sort of unpredictable, whereby you can't tell when you're going to experience this behavior. It depends on how much activity is in the cells of the brainstem to regulate that switch, if you will. What's the next? So the diagnostic criteria for this, so repeated times of arousal during sleep where a person can, again, talk, laugh, shout, make noise, or perform complex motor behaviors, punching, kicking, running movements related to the content of the dream. Patients will recall the dreams associated with these movements or sounds. And there's no confusion or disorientation. So bed partners will often wake up, whoever's doing that, and the person will often recollect what's going on without confusion. And a sleep study would show increased muscle activity during REM sleep. So that's a diagnostic if that's seen. Because during REM sleep, the muscles should be quiet. There shouldn't be any activity in the muscles. So that's why doing a sleep study at a sleep center would detect this problem, when at home would not be sufficient to diagnose this issue. Yeah, so I mentioned this area in the brain, in the brainstem, the pons, which is the middle part of the brainstem. So normally, REM sleep would result in the muscles being quiet, but in someone with Parkinson's, there could be muscle activity when there shouldn't be, because that cortical activity coming down the brainstem and going through the spinal canal to our muscles is seen, and these activities can result. So treatment, there's non-pharmacological things, putting padding on the floor near the bed to prevent injury or falling out of bed, removing dangerous items from the bedroom, placing barriers on the side of the bed. I've had patients who hit their head on the nightstand or dresser and injure themselves, moving furniture and clutter away from the bed. In terms of medications, only 2 medications have been shown to be effective, so melatonin and clonazepam. The clonazepam is the more effective of the two, so it tends to work well if tolerated. Only side effect truly is drowsiness, and typical dosing is 0.5 to up to 2 milligrams or so. Since that's a prescription medication, we oftentimes do start with melatonin, available over the counter. Dosing, typically 5 or 10 milligrams, although studies have been done using dosing as high as 50 milligrams. Now, I have patients, I think I have a patient on 40, I don't have anyone on 50, but it requires high dosing because, again, it's a melatonin deficiency syndrome. So people say, well, I'm told I shouldn't be on melatonin every night. That's for the general population without melatonin deficiency, because melatonin typically is taken for time zone travel changes or shift work changes where you're altering your circadian rhythm voluntarily. In Parkinson's, this is an involuntary movement, and we know that there's a deficiency. Since it's not predictable when this will happen, we recommend taking it every single night. And so in my practice, we typically start with melatonin, and if we've got 2, 10, 15 milligrams and it's still not sufficient, I'll add clonazepam to it, and patients will take that combination. Insomnia, another very common issue whereby there's difficulty initiating sleep. That's classical primary insomnia, difficulty falling asleep at the start of the night. Secondary insomnia is difficulty falling asleep after waking up in the night. So for treatment of insomnia, it's a lot of work that's discussed with regards to improving sleep hygiene. So sleep hygiene are the behaviors and routines that we all do to get ourselves ready to fall asleep. So this includes turning off screens. So TV should not be in the bedroom if you're having difficulty with insomnia. Making the bedroom only for sleep, putting away devices, tablets, phones, avoiding eating or exercising close to bedtime, keeping the bedroom cool. There's a variety of different sleep hygiene recommendations. There's cognitive behavioral therapy, so there are psychologists who are trained to do talk therapy to help a person then sleep, especially patients who have anxiety as a that interferes with their ability to fall asleep, ruminations. A cognitive behavioral specialist can be quite helpful. Reviewing medication, so to make sure that someone is not taking medication close to bedtime. And it's not just medications, it's even certain foods. So a patient this morning with Parkinson's who said he had trouble sleeping for the past several nights. And then his wife turns to him and said, well, it was the cup of coffee that you were having right before going to bed. So not only was he caffeinating himself, but then instead of going to the bathroom once per night, he was going 2 or 3 times. So when asked why he started drinking coffee before bed, he wasn't sure, but he wanted to do it. Melatonin can help with insomnia as well, both primary and secondary. So for primary, regular melatonin. For secondary, there's melatonin TR, time-release melatonin, also available over the counter, so you can try that as well. And then there are prescription medications. So not all medications for insomnia are particularly helpful for those with Parkinson's. So as an example, the category that works like Ambien, we avoid that category because Ambien can cause disruptions in stage 2 sleep, which is sleepwalking, sleep eating, and that can be dangerous. So instead, we use one of these 3 categories. So there's a melatonin receptor agonist that can be used, which binds to the melatonin receptor, similar to melatonin itself. There's doxepin, which is a histamine blocker, but it's safer to take than other classical antihistamines. So we don't want people to take Benadryl because that can contribute to confusion, but this one tends not to. And then my favorite prescription category is the last one. This one works on an orexin receptor, which is another receptor in the brain that regulates the circadian rhythm, and I'll talk about circadian disorders next slide. But the orexin receptor helps to promote wakefulness. So if you block it, that's what the term antagonist means. It blocks your orexin receptor, it promotes sleep. So there are a number of medications listed there that are helpful. Elsomra, Dayvigo, Q5B, those are brand names for those last 3 medications. So that's a newer category. Why they're preferred is because they are very specific for a receptor involved with the circadian rhythm in the brain. So they don't work just to knock someone out and cause other side effects. This is very specific for the sleep centers in the brain, and they don't have any after morning effect. They don't cause a groggy feeling in the morning. They'll wear off completely by the following morning. So that's another plus. So there's circadian disorder. So this is also a common issue where people have difficulty falling asleep when they should and waking up when they should. So we see commonly what's called the late sleep phase syndrome, where instead of going to bed around 10 or 11, patients are starting to go to bed at 2 or 3, and that becomes a routine, and they'll wake up at 10 or 11. So that's a shift, the late sleep phase syndrome. There's a shift in what the normal sleep pattern should be like. And why do we have a sleep pattern? It goes back in the millennia to the light. So our circadian rhythm is synchronized to the Earth's rotation, and external cues called zeitgebers are important to tell our brain when we should be sleeping. So when the sun goes down, so after the sun goes down, that lack of light then triggers the suprachiasmatic nucleus in the brain to then regulate our sleep. And then when the sun comes up in the morning, then that's a trigger for us to awaken. So that external cue is quite important. Again, in Parkinson's, there's desynchronization of that. And of course, in society in general, with devices that produce this light that further impacts on our sleep, then the signals become impaired, and this results in circadian sleep disorders. So the circadian sleep disorder is tied in with other bodily functions because as we sleep, our heart rate goes down, our temperature decreases. There's a variety of physiological parameters that also change when we sleep. And so if we look at the neurochemicals involved in this process, circadian melatonin is blunted in Parkinson's, and this causes dysfunction. So if they did a study where they monitored the 24-hour plasma melatonin concentration in Parkinson's compared to control. So this is, while a person's awake and when they go to sleep, this is how much melatonin in the bloodstream is being secreted in someone with Parkinson's compared to those without. Much more melatonin. So you can see there truly is a deficiency of melatonin that accounts for a lot of these sleep disorders. Now we'll move on to discuss another common sleep disorder, restless leg. This is much more common in Parkinson's patients compared to the general population. The criteria for restless leg is an urge to move the legs, usually associated with some creepy crawly sensation called paresthesias. Onset or worsening symptoms when at rest. So hence, when person's lying in bed trying to fall asleep. Relief of symptoms with movement, and complete relief immediately or shortly after initiating movement. And then also, again, related to worsened in the evening compared to the morning. And that creepy crawly sensation is described as a variety of other things. So if you experience any of these other types of symptoms, then it may be that you're suffering from restless leg syndrome. Now, certainly there's primary restless leg not associated with Parkinson's, and then secondary restless leg. So secondary restless leg, Parkinson's disease is one common cause of that. There are a variety of other things that can result in this, in restless leg. And then we look at medications, of course, because anything that blocks dopamine will result in, or can result in worsening restless leg as well. So the treatment of choice for this include medications that we use in Parkinson's. So dopamine agonists are approved for restless leg syndrome, as well as levodopa proper. Other things that are helpful. Well, I'll start here with non-pharmacological treatments. So non-pharmacological treatments are, avoiding things that could be triggers, like caffeine, alcohol, antihistamines. So another reason not to take Benadryl products if you have restless leg. And then for pharmacological treatments, I mentioned dopamine agonists and levodopa. And then there are another category called gabapentinoid products, so gabapentin and mechadol, which is Horizon, and pregabalin, which is Lyrica. Those are also quite helpful for restless leg. If a person is identified as having restless leg, we will also routinely check iron levels and ferritin levels because this condition is provoked by iron deficiency. So treating the iron level will oftentimes be sufficient of a treatment for the restless leg syndrome symptoms. So iron supplementation, we typically start with an over-the-counter classical iron tablet, Take it 3 times per day with vitamin C to enhance absorption. For those who can't take oral iron due to constipation, since iron is constipating, and since constipation is such a common problem with Parkinson's, then some of our patients need intravenous iron. So I'll arrange for them to get intravenous iron typically at an outpatient setting. Now, periodic limb movement disorder is another sleep disorder, but unlike restless leg, which I mentioned is a voluntary movement, so there's a sensation, an uncomfortable urge to move, but the actual movement is voluntary. A person with restless legs moves a limb in order to relieve the symptom, and that occurs in the awake state. This occurs in the sleep state, and it's involuntary. So while a person's asleep, they may experience movements of their legs and feet, so extension of the big toes, flexion of the ankles and knees and at the hip. So there could be large or smaller movements of the limbs. It occurs in sleep, so typically it's non-REM light sleep, and it could occur repeatedly, multiple times overnight, so as often as every 5 to 90 seconds. And there could be a lot of variability day to night with this, night to night with this too. So to diagnose this, again, a sleep study would be quite helpful because they can actually quantify how many leg movements occurred over the course of the night, because they have something attached to the limbs, a sticker to a machine, which every time you move the leg, the machine picks up that signal, and they'll count how often that happens overnight. And we know about screening for this condition because oftentimes the bed partner will tell us, my spouse will kick and move the limbs multiple times, or if a person lives alone, they'll say, well, I'll find the bed covers off to the side or on the floor in the morning, like giving the appearance that their sleep has not been restful. So this condition is very treatable, and it should be treated because it also leads to non-restorative sleep. Now, why that's the case is because of these, it's not only the movement, but a person can also have a large enough movement to actually have a brief awakening from sleep. And the awakening can be so brief that the person doesn't even realize that they're awakening out of sleep. Again, that's something that's quantified on the sleep study. But having non-restorative sleep will cause daytime fatigue, excessive daytime sleepiness, and so this, if identified, should be treated. Treatments, the dopamine agonists again, so lopinirole, pramipexole, levodopa is helpful. So having a person take Cinemet CR, like a long-acting levodopa or Rytari at bedtime, will help provide some dopamine level overnight. And then benzodiazepines, of which clonazepam is the preferred agent here. So that medication will also for this condition. So you're hearing a recurring theme that oftentimes our goal is to use one medication that can have multiple benefits. If a person has severe behavioral disorder, periodic limb movement, clonazepam can be used to treat both of those. Now, the one issue where clonazepam would not be used is with this one, that's sleep apnea. So sleep apnea is why a person has turbulence of airflow and even cessation of breathing temporarily due to obstruction, typically. So that obstructive sleep apnea is the most common type, so abnormal function of muscle of the upper airway that causes that turbulence of airflow. But central apnea is also common. So central apnea means that the brain is not sending a signal down to the structures of the throat to allow them to function in a coordinated manner to get the oxygen in sufficiently. So there's a decreased drive to breathe in sleep due to this function, again, at the level of the brainstem. So both of these are important to identify. Clonazepam wouldn't be used in the setting of sleep apnea because that can cause worsening of obstructive sleep apnea, so there's that caveat. For obstructive sleep apnea, that can be diagnosed at a home study central, can only be diagnosed at a sleep study done in the lab. So again, I highly recommend a sleep study in the lab over at home. And important to treat sleep apnea because that's been consistently shown to put stress on the heart and brain. So it can result in increased risk for heart disease and stroke, and poor headaches and memory, even effect on mood. You can't underestimate the effect of sleep on mood either. We all know that when we're sleep deprived, that we can be more edgy and short-tempered, and so now, not treating this can also obviously impact on mood, and really, if looking at all these sleep disorders is important if you're sharing your bed with a bed partner, because it's not just your sleep that's affected, but your bed partner's sleep also. So if you're both not sleeping well, then that's impacts on quality of life too. So having sleep disorders treated is critically important. For sleep apnea, treatment of choice is using CPAP, so that's continuous positive airway pressure. Some people need BiPAP, which is bi-level, where the pressure is different between inhalation and exhalation. For those who don't tolerate CPAP or have a milder case of sleep apnea, there's an oral appliance, which is something that a dentist will fit you with that will keep the jaw protruded forward to open up the airway. And there's also even other devices. So there's a device called Inspire, which is a medical device implanted in the chest with a wire that goes to the palate. So when you take a breath, the device will send a nerve impulse to the palate to cause it to move out of the way so a person can breathe without obstruction. So there's various ways of treating sleep apnea nowadays. And the devices have become smaller, the CPAP devices, and more easy to use. So even patients who have said, oh, I tried using sleep apnea 5 years ago and I couldn't tolerate it, I still haven't gone back to a sleep specialist to see what else has changed over time. Technology is always evolving, and there might be something that they find more readily usable now. So we looked at, when we think about Parkinson's, then it's really the motor symptoms are what we see, and we've touched on some of the non-motor symptoms that are below the surface that someone may not recognize is happening in that person just by looking at them. And when it comes to sleep, I mean, all these issues, so tremor, stiffness, anxiety, hallucinations, pain, urinary dysfunction, those can impact on sleep directly. So if a person is having pain, then, due to their stiffness, then they're going to have trouble falling asleep. If they're getting up multiple times at night, by multiple, more than twice a night is too many, then that's going to cause sleep fragmentation. So it's not uncommon for me to say, well, it would make sense to see a urologist to try to reduce the urinary frequency to improve sleep. If a person is experiencing hallucinations or anxiety related to sleep, then managing those directly. So these are other factors that can impact on sleep quality. So when we think about motor symptoms like tremor, stiffness, it's important to discover precisely when patients are experiencing this in relation to when they're going to bed. So we'll ask questions like, do you have trouble falling asleep due to symptoms, turning in bed, adjusting bedclothes, due to tremor, stiffness? If the answer is yes, then we'll use dopamine medications to try to keep them more in an on state. So longer acting preparations are often used. So I mentioned Cement CR, Vitari, some of the longer acting dopamine medications like Nepro patch. The longer acting agents, the better to help with sleep. Anxiety, worrisome thoughts. I talked about cognitive behavioral therapy, so seeing a psychologist is helpful. At the Chase Family Movement Disorder Center, at each of our main centers in Cheshire, Rhode and Mystic, we have embedded within our program a neuropsychologist and a social worker who can help patients in this regard. Medications such as SSRIs like Lexapro or SNRIs like venlafaxine or Effexor can be helpful. There's another one called mirtazapine that is taken at bedtime. Its side effect is sleep, so that's quite helpful for sleep. Trazodone is another one that can also work on sleep and mood. If hallucinations are interfering with sleep, then we treat those directly. This is also unfortunately common whereby, due to the fact that it's in sleep, the room is dimly lit, if at all, and the person may waken up to use the bathroom, and because of the lighting, the person may experience a visual hallucination that can make it difficult to then fall back asleep, especially if it's a frightening one. So a person, and I've had patients mention this about a stranger trying to harm them or a loved one, having strangers in the bedroom at the same time. I had one patient last week who was his wife, when she got up in the morning, she said, why is this pile of towels here by the bed? And he's like, I got them for the 3 other people in the room in case they want to shower after they woke up. She's like, there's no one else, in the room. So even behaviors can change to the extent that it puts a person at risk of falling in the night if they're trying to get things or avoid things because of what they're seeing. So it's important to treat hallucinations as well. Variety of medications. Quetiapine is very commonly used, or Seroquel, because it also helps improve sleep as a side effect. Clozapine is used for patients who have severe hallucinations because it's the most potent of them. And then another one is pimavanserin or Nuplazid. That one is specifically FDA approved to help with sleep, to help with hallucinations. Urinary symptoms, really important to treat as well, and this is generally very treatable. So important to see a urologist in my building in Cheshire. We have a urologist that we partner very closely with right on the second floor of our building. We refer many patients to see him. Anything from frequency, urgency, nocturne, which is frequency of urination overnight, incontinence. If any of these things are occurring, there are a variety of medications that can be helpful. So these are some of the more common ones that will not impact on a person's Parkinson's or cognitive function. There are certain bladder medications that can worsen cognitive function, but these are well tolerated, like Machado, for example. Botulinum toxin injections, also very helpful. So for patients who, for one reason or another, aren't seeing sufficient benefit from medications or other interventions, then Botox into the bladder can be quite helpful. So the bladder is a muscle, it's smooth muscle. So in Parkinson's, there's muscle stiffness, and the bladder becomes stiff also. So the bladder's stiff, it's not going to relax enough to hold enough urine that's produced as you sleep in order to hold it. The volume is much smaller. That'll cause much more urgency, and hence a person needs to get it multiple times overnight. By delivering Botox, you're relaxing the muscles of the bladder, allowing it to hold more volume of urine so that it helps to manage that particular symptom. And now the next section is fatigue. So fatigue is very common and underreported issue with Parkinson's. So when we think about fatigue, we always look at some cardinal things. We ask, well, is it a sleep issue? We treat that first. So we wouldn't, put someone on a stimulant if they're not sleeping well at night, because I already mentioned how important it is to treat the sleep disorder. So fatigue is a is a byproduct of poor sleep. You treat the underlying issue, not the symptom. Other things, medication side effects. So as mentioned, some medications can impact on the person's sleep. Even I've seen patients whereby they may take even Parkinson medication, amantadine being one of them, that is somewhat activating, and we're taking it at bedtime. Amantadine, regular amantadine should not be taken at bedtime. Only recovery, which is a long-acting amantadine, can be taken at bedtime. But regular should be several hours away from bedtime, so as to not interfere with sleep. Other medical conditions like a thyroid disorder, anemia, can impact on a person's fatigue level. Annually, as a standard of care for my patients, I screen them for these issues. So I'll screen them for thyroid and various vitamin deficiencies and anemia. So if any deficiency is seen, then we treat that deficiency. Again, it's treating the underlying problem, not just the symptom. Vitamin deficiency is very common with Parkinson's. Why? Malabsorption from the gut, typically. Even with no change in diet, we know that people with Parkinson's may not absorb vitamins and nutrients from their gut properly. And so we check in the blood. If there's a deficiency, we treat that based on how deficient a person may be. So we look at B12, folic acid, iron, thiamine, vitamin D, E, thyroid again. So we do a lab panel annually, and then we'll keep that under closely monitored. Depression is another common cause for fatigue. So we'll screen patients for that. And depression is much more common in Parkinson's also. And it's not just due to the fact that a person has chronic neurological condition, but it's a chemical depression also. We know that dopamine is a neurochemical that results in a sense of euphoria, the feel-good chemical. So if you have a deficiency of dopamine, then the opposite can occur, the sense of despondency, depression, demoralization. So treating Parkinson's with dopamine medications, and if that's not sufficient, using antidepressants can help improve fatigue. And some antidepressants are activating also. So there's one called Wellbutrin, bupropion, which acts on dopamine specifically, and it is activating to some degree, so that is often a helpful medication to use. Now, after screening for all of that, we then say, okay, maybe a person has just excessive daytime sleepiness from Parkinson's proper. Excessive daytime sleepiness increases as Parkinson's advances, and anywhere from 15-20% early up to 46% as the disease progresses, so it's very common. So even after we screen for all those things I just mentioned, a person may still be left with excessive daytime fatigue, in which case then we look at treating that directly. So the treatment directly, we always encourage exercise. So having programs like what you have here, we participate in physical therapy and exercise is really important to help combat fatigue. And you may say, well, if I exercise, will I feel more fatigued? No. The therapists are shaking their heads, no. You'll feel more energized, more invigorated. You'll move better. So the benefits of exercise is top of the list. Other non-pharmacological strategies are using bright light therapy. There's a lot of great work looking at bright light therapy. Getting a bright light like 10,000 lux light in your home, especially in fall and winter. When the sun sets much earlier, can help promote wakefulness during those evening hours. And then medications. Typically, one would start with caffeine, since it's the most common stimulant available. For those who say, well, I don't drink coffee or tea, then you can use pure caffeine tablets. So I'll prescribe caffeine tablets over the counter, Vibrant, no dose. Those tablets are 200 milligrams each, cut in half. It's like having a cup of coffee for 2 cups of coffee per tablet, so you split it in half. Half a tab in the morning, half a tab with lunch, and that could help. For those who have, who don't tolerate that, then my favorite prescription medication is modafinil, also called Provigil. It's used for a condition called narcolepsy, the sudden urge to sleep. But modafinil, very well tolerated, doesn't cause jitteriness, it won't interfere with sleep at night. So it's a great product to use, starting with 100 to 200 milligrams. If that's not sufficient, then we switch into our modafinil, which is a more purified form, a bit more potent, which is Nuvigil that can be used. Other things, we do have some patients on methylphenidate. So if they tolerate caffeine, but it's just not doing it for them, methylphenidate can be a choice. So that's called Ritalin. So Ritalin can be used as well. And then there's a medication that's used for Parkinson's motor symptoms, that's FDA approved for motor symptoms, to decrease off time, called istradefylline, the Norians. So the Norians, it interestingly works on the A2A receptor, the adenosine receptor, and it blocks it. What other thing blocks adenosine? Caffeine. So it has a direct effect on the same receptor that caffeine does. So it is activating. Sleep does significantly reduce after 3 months of use in patients at 40 milligrams daily to a statistically significant result. So for patients who have this sluggishness through their day, that they feel stiff and slow and they just have decreased energy, Norians could be a very good choice. So in summary, variety of sleep disorders that I reviewed, common Parkinson's symptoms that can impact on sleep. We look at these factors in association with whether fatigue is present, and then once those factors are screened out, we can treat excessive daytime sleepiness directly, and I hope that you're now more aware of pharmacological and non-pharmacological treatments for each of these things and the importance of treating them, that these are treatable conditions and can have a big impact on quality of life. So with that, I'll take any questions in the remaining couple of minutes. Yes?
So I've always heard that sleep quality declines just as a function of getting older. Is that true? And if so, how do you sort that out from these other disorders?
Yeah, so sleep quality and quantity both decrease as we age. That is true. It's a matter of what's within normal versus abnormal. So so the key question I'll ask is, do you feel refreshed in the morning? As a really basic screening question. If the person says no, then we'll delve into what time you go to bed, what time you wake up, how long does it take you to fall asleep, and look at certain things like if it takes more than 10 minutes to fall asleep, if you're waking up more than twice per night to use the bathroom, if you're snoring, if you're flashing in sleep, if you're ruminating, if you have one of these, could that be with the normal? Certainly, but now you put them all together. People with Parkinson's can have not just one of these, but multiple one of these, and that's really going to be too disruptive to be within normal limits. And certainly rapid behavioral disorder, that's not a normal part of aging. Periodic limb movement disorder, sleep apnea, these are abnormal. So if they screen positive for any of these things that are not normal part of aging, then you try to talk to them correctly. Yeah, so looking at what are true disorders that are not normal part of aging with sleep, and then how many of these are in combination and the severity of them, and then you develop them. That's a great question. Yes.
Question. Recently, my husband had a blood test done, and the first time I found his ferritin was very high, copper was low, and we requested a test to retest him. And I noticed something about serum. What's the difference between testing serum ferritin and regular ferritin?
Oh, it's anonymous in this instance. So serum is in blood, but a high ferritin often is seen as a marker of inflammation in the blood, So when we think someone, I'll go back to the instance where we check ferritin. So if we check ferritin and someone presses a slide, we always have to check it iron and trans ferritin. Because ferritin alone is not sufficient, because if a person has some underlying inflammation in the body, the ferritin may be high, even though the trans ferritin and iron stores may be low. So in the setting of an elevated ferritin, other things to check for are other inflammatory markers. BSR, CRP. Oh no.
And you also mentioned caffeine. Coffee just to have terrible.
Yeah, so that's a jitteriness issue. So if that happens, then using the other interventions, specifically modafinil, if you're looking at some other pharmacological intervention, modafinil won't cause that jitteriness in worsen. Yes.
Would you recommend, or as it relates to melatonin, with a patient who needs to speak with their physician in order, or can we just do that on their own? Or is that has to be incorporated into all the other medications? Are there any medications that interact with melatonin?
Yeah, that's a good question. There really isn't. So a person may initiate melatonin, but always important to let each of your doctors know that you're on it. So making sure that your medication list includes any other supplement that you're on, so that they can see the list in total. But melatonin, it is natural, and it shouldn't interact with any other product.
And you said 5 to 10 milligrams?
Yeah, starting at 5 typically, in this instance, yeah.
Okay.
For those who, everyone has different medication sensitivities. Those who might be more sensitive historically to medication start at 3 is advised, but most people start at 5.
Is there a dosage of melatonin that's too much melatonin?
The research is up to 50, so, and like I said, I don't have anyone who's taken that much, but they've looked at doses up to 50 milligrams as being.
You don't go above 50.
Yeah, you should never have to. Yes.
I attended the APDA conference back in the spring. One of the speakers mentioned melatonin is a supplement, so it's not regulated by the FDA.
Right.
Therefore, when you go to the drugstore, you don't know how much you're actually getting. If you have 10 milligrams or maybe less or more, can you speak to how you actually know what you're getting with melatonin?
Yeah, she mentioned looking at specific labeling on the bottle to see if there's a seal of approval that it is more regulated. So when I ask patients to take melatonin, that's generally what I'll mention. I won't direct them to a specific brand per se, but rather one that does have a label of seal of approval, of some regulation. Yes.
Over time, does the body develop an immunity to melatonin, so long term?
Right, yeah, so patients can continue to take the same dose for a while, for years. Certainly, if things worsen, it might be only because the symptoms are getting worse, not because the person's acclimating to the dose amount. All right, well, thanks so much for your attention, for attending.
Thank you. Can we get copies of the slides?
I did record this, and we will put it up on our website. So if you're at rvdahealth.org/Parkinson Center, we have a great website with a lot of information about our events, our team, our services, and there's resources. And under the resources, we're going to have some of our past videos, so you can see that.
Great, thank you.
It's the library's building.
Yeah.
Awesome. Thank you.